disorders associated with ADH. And we'll go more into the actual system right now in terms of the endocrine system. But ADH is your antidiuretic hormone, and your excuse me, and your antidiuretic excuse me, your antidiuretic hormone is it's what's responsible for ultimately the or the releasing water from the body, and it deals with primarily looking at its storage in the posterior pituitary accordingly, but we'll talk more about that later on. Your antidiuretic hormone, as with anything, you can either have too much or you can have too little, all right? If you have too much, you have SIADH, syndrome of inappropriate ADH, okay? And we talked briefly about that when we talked about being on a ventilator, okay? That when your body perceives that it's dry, it doesn't have enough fluid, doesn't have enough water, it releases ADH. And we talked about that when people were on a ventilator, you had all that positive pressure in the thoracic cavity. And all that positive pressure in the thoracic cavity pressed down on the baroreceptors that are on the, in the cardiovascular system, so that the body thought it did not have enough fluid. So the body thinks it doesn't have enough fluid. So subsequently, it releases more ADH. So subsequently, people on a ventilator always have about 1 kilo or 2.2 pounds more of water on average. So that once they're taken off the ventilator, that fluid rapidly dissipates. Diabetes insipidus is when, instead of retaining fluid, you lose fluid accordingly. So with diabetes insipidus, there's a decrease in terms of the release of antidiuretic hormone, so that when people have the causes for diabetes insipidus primarily is either a pituitary tumor in terms of the resection of it, or it could be head trauma. So either or could be a cause. So SIADH, you have too much ADH, most commonly resulting from being on a vent. DI, diabetes insipidus, you have too little ADH. It could be from a resection of a tumor, subsequently not having enough tissue to subsequently produce ADH, or the person could have head trauma that could interfere with the release of ADH. So in terms of looking at, the most common, it's even though it's not listed here, I'm going to fix the slide, because when you look at the literature, the most common cause primarily of why we see SIADH in a critical care setting is in relationship to ventilator management, okay? And a common cause would be malignancy. It could be certain central nervous system disorders, as well as certain medication therapies. And with ADH secretion, it's, either because even if you have a normal or low osmolarity. Now, remember, osmolarity tells you how concentrated particles are within the vasculature. So that if you have a low osmolarity, that means that you have too much water. If you have a high osmolarity, that means that you have too little water, okay? So that ADH secretion in SiADH is inappropriate because, and the lab values that you find is either you have adequate osmolarity or a low osmolarity. And it's also somewhat common in older adults. Syndrome of inappropriate ADH is that you have an increase in terms of antidiuretic hormone, an increase in water reabsorption in the renal tubules, excuse me, an increase in intravascular volume, and a dilutional presence in terms of sodium, and subsequently a decreased serum osmolality. Okay, so remember that osmolality is when osmolality is deals with the concentration of particles in your vasculature, so that when you're looking at serum osmolality that is increased, that means there's more particles, and that generally you're looking at a serum osmolality of greater than 350. If it's hyper, if it's hypo, it's generally you're looking at under 300. But SiADH basically means retaining fluid, specifically water. And if you retain more water, then it's going to be dilutional and your sodium level is dropped. So there you go. So in terms of the pathophysiology, you're going to see with SiADH a retention of fluid. Your serum osmolality is going to be low, or osmolarity is going to be low. Once again, you're going to have dilutional hyponatremia, means there's more water and less particles, specifically sodium, and subsequently hypochloremia. And then your urine is going to be concentrated. So that your clinical manifestations of SiADH is you may see muscle cramping and weakness. You may see thirst, all right? You may see dyspnea. You may see, fatigue, dull sensorium accordingly. Now, with your serum sodium levels going extremely low, you could see the big thing is actually, in most clinical settings, you're looking at a sodium level of less than 120 to 125, and then the person's placed on seizure precautions. Okay, so that a low sodium level is a cerebral irritant, if you remember from electrolytes. So a low sodium level is a cerebral irritant, okay? And the extreme of that is going to be seizure activity. And then, so that subsequently, if you have something that's an irritant, you could develop cerebral edema. With cerebral edema, subsequently, there's usually how it goes is seizures, edema, lethargy, coma, then death. So in terms of a low sodium level, the vomiting, abdominal cramps, muscle twisting, once again, because you're not having an adequate, exchange in terms of sodium and potassium, because you don't have enough sodium, and subsequent the seizure activity accordingly. So in terms of looking at SiADH, you're looking at two measurements simultaneously, and what's in the blood and what's in the urine, okay? So whatever it is that you hold on to in the vasculature, subsequently you're going to have the opposite effect in the urine. So in terms of serum osmolarity, remember that you have more water than particles in SiADH. You're holding on to fluid, specifically water. So you have more water than you do particles. More water than you do particles. Okay? So therefore, your serum osmolarity is going to be low. Okay? Now, your urine specific gravity is going to be more concentrated. It's going to be higher. So remember that the specific gravity of water is what? 1. So as your urine becomes more concentrated, you're going to see is going to be low because it's more diluted. But your urine is going to be more concentrated because there's less water. Okay. So how are you going to fix this? Well, you're going to treat what's causing it. Now, if you're on a ventilator, you're not going to take to manage their fluid volume. Okay. So that you're going to look to what's normal fluid volume and normal serum osmolality. Okay. So that your serum sodium level should be, work to be greater than, 125. Remember, your normal sodium is 135 to 145. So that you're in a very dangerous range once you are hitting 125 and you start to go below that. So you obviously want to concentrate your sodium level. So if you're fluid overloaded, you have too much water, then it only makes sense that you're going to fluid restrict. So remember that the average adult gets 12 to 1,500 milliliters of fluid a day as intake, all right? So that you want to restrict fluid to at least 800 to 1,000 milliliters a day. Now, if it's severe enough and it's below 120, then you have to give hypertonic, hypertonic saline, which is 3 to 5%. And you have to be very careful with that. To vasculature. So you really should be giving hypertonic saline in a central line, not in a You can give diuretics, but you have to be careful with the diuretics that you give. Because, like, for example, Lasix takes off water. All diuretics remove water, but Lasix also takes off sodium and potassium, all right? So that your problem is that your sodium level is low, so you don't want to necessarily sodium level is greater than 125, yeah, you can give it. But if it's not, then you have to consider your alternatives, and you may have to go to something like Edecrine as the electrolytes correct themselves. So nursing management, you're looking at fluid restrictions. You're looking at ice chips because, we'll work on the moisture in the mouth. They have to give them potassium so that oral as a replacement later on. The fluid balance you want to make sure that that you have adequate blood flow back to the heart. And then obviously you're looking at seizure precautions. At okay, so diabetes insipidus, when you're looking at the etiology, you're looking at it's neurogenic primarily, and it has to do, as I mentioned earlier, with either a tumor or some type of head trauma, and could also have nephrogenic components in terms of renal disease, or somebody could in terms of psychogenic, has to do with so that people with diabetes insipidus will have clinical manifestations presenting with polydipsia, polyuria. Polydipsia, you're thirsty. Polyuria, you're putting out a lot of urine. You have large excessive amounts of urine, and that's no exaggeration, of 5 to 20 liters accordingly. Your urine specific gravity is going to be low because now you're getting rid of water, all right? So that you're going to have a lot of water in your urine. So subsequently, you're going to get close to that 1.000, which is specific gravity of water. Your serum osmolality is going to be higher because you've lost water, so therefore there's more of a concentrate of particles, so you'll be hypernatremic. And there could be fatigue because of the nocturia, as well as general weakness. You're going to have a severe fluid deficit, subsequently weight loss in relationship to fluid loss, constipation, a poor tissue turgor, and the constipation would be in relationship once again to the fluid loss. Poor tissue turgor, remember that when you pull your skin up, it goes down quickly, right? Hypotension because of the fluid loss, tachypnea in related to fluid loss causing the hypernatremia, which is a CNS depressant. So there's different tests that can be done. You're going to get a complete history and physical. Then you're going to look at your water deprivation test. So you'll see if it's neurogenic versus nephrogenic. And that relates to the administration of vasopressin, which is basically facilitating the release of the production of ADH, right? Vasopressin in and of itself is not ADH, but it's like kind of like when we talked about the clotting cascade, and we talked about tissue plasminogen activator, so that the activator is what makes the plasmin. Well, the same deal here. Vasopressin works with facilitating ADH release. So that would
Can you please repeat the how to differentiate between central DI and nephrogenic DI, please?
Yes. Central neurogenic just simply means it comes from a nervous system issue. Whereas if it's a nephrogenic, that means there's something wrong with the kidneys. So the kidneys are not allowing ADH to do its job. So central neurogenic means that you're not releasing ADH. Nephrogenic means that the ADH is released, but the kidneys are not allowing it to do its job. So therefore, water is not reabsorbed. So one is making it, the other one is the utilization of it. So centroneurogenic is the production of it. Nephrogenic is the utilization of it. The underlying cause, you have to maintain fluid and electrolyte balance. And in terms of replacement of water, I think I might have said this to you. Replacement of water is you either ingest water through your GI tract, or if you're going to give water intravenously, you give D5W. And the reason for that is that once D5W goes into the vasculature, insulin will carry it into the cell. So then what's left? Free water. Whereas normal saline, it's going to stay in solution in its concentration. So hypotonic saline 0.45% you could give, but usually what you see administered is D5W as well as actual free water. So if you're taking care of a patient, right, and that just deals with hypernatremia, not necessarily specific to DI, and you see like 250 cc's every 4 hours administered, that's really to treat the hypernatremia, so you're going to look at sodium levels. With diabetes insipidus, it's going to be a really dramatic loss of water, so subsequently you want to replace water, and you can do so by the administration of water or D5W. And that's why, if somebody's suffering from DI as a result of they had a hypophysectomy because they had a pituitary tumor removed, and it says replace fluid CC for CC, it's water that they're replacing, not like milk, orange juice, tea, coffee. It has to truly be water. That's going to be administered DAVP, and that can be administered nasally. Also, you can give you can also administer it intravenously. Pitressin IV, which is also a form in terms of looking at the replacement of ADH. Okay. But once again, the pitressin, that would be somebody in the ICU would get that IV, because the intake and output has to be extremely, extremely closely monitored. Okay. DDAVP can be given outside of a critical care setting, but it's the urine output is what really, really, really has to be closely monitored. Okay. Nephrogenic DI, you're looking at low sodium diet as well as thiazide diuretics. Now, nursing management, obviously, as I mentioned to you, you're going to administer the supplementation, either PO or IV, and it has to be water. So you're looking at water by mouth or D5W. You can give half normal saline or 0.45 hypotonic saline, but that's not, usually it's D5W. You're going to have strict INO. You're going to look to the weight of the person. Remember, daily weights tell you fluid volume. Okay. Excuse me. Daily weights tell you fluid volume. Weekly weights tell you nutritional status. Okay. And then your urine-specific gravity has to also be monitored, because remember that as your specific gravity goes to closer to 1, then it's water. It's more dilute. As it goes closer to 10, 10, 10, 20, above 1005, you're looking at a more concentrated urine. You need to administer DDAVP, and then, or if you're in the ICU, Pitressin. And that's where, another thing to consider also is that you're always reading the label. Even though nowadays we have everything now computerized, and you have barcode, medication administration, all this stuff, you really have to be very careful as to what you're administering, because look-alike, sound-alike medications, it's, once again, it's, for now, it may be coming from pharmacy and it may have the right barcode on it, but still read the label, because Pitocin and Pitressin are two medications that look alike, sound alike, but do very different things. Obviously, Pitocin is something that should only be in labor and delivery, whereas Pitressin deals with this situation. And that's it. Okay, so I'm going to let you guys go early, and those are the 2 topics for today: diabetes and its forms, and then